Our first speaker of the day, Dr. Abdulaziz Sachedina. Professor Sachedina is a professor and IT chair in Islamic study at George Mason University in Fairfax, Virginia. Dr. Sachedina, who has studied in India, Iraq, Iran, and Canada, obtained his PhD from the University of Toronto. He has been conducting research and writing in the field of Islamic law, ethics and theology, Sunni and Shia, for more than 2 decades. In the last 10 years, he has concentrated on social and political ethics, including interfaith and interfaith relations, Islamic biomedical ethics, and Islam human rights. Dr. Sachedina will share with us his reflection and his knowledge about end-of-life Islamic ethics. Thank you.
Well, good morning, everyone, and I am pleased to be back in Toronto. This is my second home, by the way, so it's always good to be here with you all. This is what we are supposed to read it out, right? Is it? Not necessarily, okay. So at least you know where I'm coming from, and I have no financial stakes in anything that I say here, okay. So let's come to the very important topic, and I have changed a bit my own, the title of my presentation today. I'm more interested to share with you the relativity of decision making. In such matters, I must confess that, yes, although we are speaking about religious biomedical ethics, we are still not giving you absolute views about anything. There is no absolute answer for those questions that are part of the medical practice today, and we cannot really say this is the final word and this is how it's going to be. So even as trained as a Muslim chaplain, I am also chaplain in the University of Virginia system, where I go and see my patients in a different way than the academics that I do. And I think that what I find to be searching for is a universal language. How we can help medical professionals, social workers, ethicists, and also even the imams to understand that there is a universal language that touches all of us at the time when we are making decisions about the final issues in our lives. And who is it who has not faced it? So we are really at the juncture of what I would call the relativity of the situation in which we are developing skills, how to help people at the end of life. And also at the same time, we are seeking for more predictable, certain answers. How exactly are we going to inform our patients, their families, and everyone who is involved in the final, decision making? So let's look at the palliative care. And I'm more interested to point out to you that today there is a need of teamwork. And I'm not talking about the imams functioning alone and the physicians functioning alone. I'm talking about how different forces and different people working in the hospital system are to work together in order to find out what exactly how exactly can we interact with the families, with the patients, with the ethicists and healthcare providers. And second is to develop rules of engagement. What kind of communication are we going to give to the families, to the patients, to the physicians who are working? And I know the tensions that are sometimes operative in the university hospital system, and I've been participating in those quite regularly. And finally, I really would think that It's time for us to globally connect with many parts of the world, because everywhere these issues are important. It's not only here, it's in African countries, Asian countries, Middle Eastern countries. Everywhere there is a problem of how exactly do we help the families, how do we help the physicians to handle a very, very tough situation. No doctor likes to make those decisions at that time without having qualms about, am I right in what I'm telling them? Or is it just the medical information that I can give them? So we are dealing with religion and culture. Culture in the hospital system, culture in the social system, where we are going to talk about those issues very sensitively. So let's move on, and I want to present to you a case. Please take a moment to read the case for a while. I could read it for you, but I want you to just concentrate a little bit on it. The case study is really a scenario that we encounter every day in the hospital systems today. Despite all the medical advancements that we have been able to demonstrate in the way we are prescribing treatments, we are still not able to help situations like these ones. What exactly, how do we negotiate that space between the family concerns, between the spousal concerns? There are sometimes very critical differences between the husband and the wife on the whole issue of how exactly am I going to deal with my situation in the hospital. Imagine this is the situation, and I'm particularly concerned about, I think, something that we have a misunderstanding in this part of the world. North America, we think Muslims are all very religious people. I want to make sure that we do appreciate what we call the diversity even among Muslims. They are not religious the way you and I think they might be. They might be culturally informed, and I call them cultural Muslims many a times. They don't know much about their religion. Honestly, they don't. There are few who know it, but otherwise there's zero information about how the religion is operating on these particular issues that are sensitive. So peripheral is in that meaning. I'm nominally Muslim. I don't go to the mosque. I don't attend any meetings. I don't even pray 5 times a day. But I'm still a Muslim. I still don't eat pork. I still don't consume, for example, alcohol, because that's what culturally I've been told. Now, these are the things that we need to keep in mind, that there is no monolithic Muslim community. There are Muslim communities, and they are all practicing different kinds of Islam. You saw that Rasuli case, by the way, in Ontario. And the Rasuli case shows quite clearly there are cultural differences. There is no textual information available on the way Mrs. Rasuli argued about the case. There's nothing in the text to prove that this is what it is. Yes, there are issues, and we'll come across in my presentation today, but I want to make sure that there's no monolithic understanding of what I'm saying. I'm not advocating any specific position. I'm just leaving for you thoughts so that you can digest them in your work every day. Now, proposed treatments. Whenever we talk about advanced directives, when there is, for example, DNR, there is no do not resuscitate. When that kind of information is available to us, sometimes the information is given by the patient, sometimes by the family. And at that time, we have a difficult moment. Who do we follow? Here in this case, for example, we find that Mrs. Awad didn't want to follow the directives. What are we supposed to do? How are we going to negotiate the space of differences of opinion? Are we going to take the side with the spouse, with the husband, or with the wife? The question arises, what does the religion say about it? Is my directive valid religiously, and my wife's opinion is not valid in respect to that directive that I've given? Is it appropriate for me to argue that way, or to show that in religious communities there is no one way of dealing with that situation? Now, here we find the treatment. How do we negotiate between obligatory treatment and optional treatment, all right? Also, the questions of quality of life arises. Not many Muslim thinkers are talking about the quality of life, because it is a slippery slope. What do you mean by quality of life? In whose opinion that quality of life? Is it something that the family decides, the physicians decide, social workers decide? Who is going to decide that? And then you have the principles, the teachings of the religion. And one of the very important teachings in Islam is la darar wa la dirar. You cannot harm anyone, nor should you reciprocate harm with harm. This is the meaning of dirar. In other words, what I'm going to decide, what I'm going to suggest, what I'm going to counsel, the medical team should have weighed very carefully where that line can be drawn. What exactly harm means? Am I going to say, is it physical harm, psychological harm? Or should I say more, family harm? It could harm the family members. If I'm going to insist on a certain way of treating, it might deplete the funding of the family. They might not have anything to live on. I had a case in University of Virginia, an Iraqi woman and Iraqi man. The man had stroke, and he was in a very bad condition. The medical team was very clear that there is no hope at all. The dispute was between mother and the children. The mother was the one who was working. She was the one who was a breadwinner for the whole family. She was taking care of the husband, she was taking care of the children, and the younger children had already gone out. They were not in the family, but they were the ones who were insisting that their father should be kept alive. It was a very touchy situation. I was called in by the team and said, can we see what Islam says about it? And honestly, it was very difficult. But the point was that the mother was right. She says, I can't take care of the family. I can't take care of my husband. I've done this for 3 years. I'm working and I'm feeding them. Who is going to look after my husband? And there was no insurance money, by the way. And sometimes those decisions are made by insurance. What kind of insurance you're holding? After all, these hospitals are not charity, foundations. They do take in sometimes, but otherwise they won't treat you for everything that you are demanding. In other words, a very touchy situation, and you won't believe something that I understood for the first time. She was talking to her family in Najaf, Iraq. The woman was. And the family of the husband was actually blaming her for what had happened to their son. So to add to all other difficulties, you have this mistrust on the part of the family, that you are the one who have caused this pain to my son, and you should keep him alive. You should not. In other words, there was now the medical team saying, we can't do anything. Believe me, and they're talking to me, we will not be able to help anything. And there was one ruling, because they were a Shia family, they were saying that the Ayatollah, the authority in Najaf was saying that if you start the machines, you can't shut them off. Once you start with LSE, you can't stop these machines. Okay, all right. So what are the conditions then? Under what circumstances we can't do that, or we can do that? In other words, I want you to imagine the optional versus, the obligatory treatment. How exactly are we going to negotiate that space in the hospital? Now, during the deliberations, use of such, life-sustaining treatments comes up in the light of strong probability that occasionally these interventions violate patients' interests. This is important to keep in mind. Who makes those decisions? How are we going to make that decision? Whether it is violating the patient's rights, violating the patient's best interests. Is it okay to keep him alive? Like in the case of this Iraqi, this was the third stroke. It was not the first stroke. And there was no hope whatsoever. Who was going to answer those questions? Is it his interest to keep him alive? And it's modern medical advancement that has created those problems. In the old days, the patient would die, would be allowed to die, so to speak. There was no intervention whatsoever. And now with the new medical treatments that are available, we are now talking about the possibility of extending life, prolonging life. What exactly is the situation with the religious biomedical ethics? Prima facie obligation to treat. Deliberations about the conditions that justify withholding or withdrawing treatment are at the center of deliberation. I'm talking about the real scenario in the hospital. We're all discussing this. What exactly are we going to do here? In the light of Islamic principles of manfa'ah, what exactly is the benefit? And compare it to the madarra, so to speak, the harm that could be caused, the maleficence that could be, emerging into this. The Sharia presumption about the duty to cure is weighed against. It is to cure. Sharia wants to say you are supposed to be curing the patient. It doesn't say you can prolong life the whatever way you want to do it. There's a very fine line in the Sharia, rulings, in the rulings of the Islamic religious law. All right? You're curing against the medical presumption about the duty to treat. Under all circumstances, this is what the physicians would tell you. I'm supposed to treat this case. I cannot shrug that responsibility. Under all circumstances, I'm supposed to save this life. Are you supposed to save the life or cure the life? That's what the Sharia is asking. Sharia is saying that if you have no hope of curing, don't interfere in the work of nature. Do you see what I'm talking about? You cannot just, impinge upon the rights, religious rights of an individual. Individual is a Muslim, or I don't know, whatever other religion might be there. But the religion is teaching that there is a very positive outlook to death in Islam in general, by the way. I must be quite honest about it. And I worked in an Imam Khomeini hospital sometimes going with the ethics committee in Tehran, and I've seen that there is almost, I would say, open-handed, welcoming. If this is the will of God, we accept it. If this is going to happen, we accept. There is no fighting. There is no combat against the evil of death, the evil of suffering. There's more accepting. Psychologically, you are more prepared to say that there's a way of dealing this. This is Mashiatullah. This is the will of God, and I'm going to submit to that. So the culture is replete with what I would say a kind of submission, that I'm submitting to the final decision of God. And it really is the question that ethical dilemma is encountered when a patient is in coma with irreversible medical condition. Are we going to help that patient? Critical question, will the patient be harmed incrementally? Day by day, it is getting worse rather than getting any better by cessation of treatment. These are the important questions that come up very often in the end-of-life decisions. Now, weighing harms with benefits, manfa'a, madarra, how do we weigh this? And Muslim jurists are very, very particular about it. If there is a 51% benefit, then you should do it. If there's 51% of harm, don't do it. In other words, if the balance is tilting towards one or the other, you make the decisions accordingly. They're very mathematical about it. If you see the way they are functioning in giving those opinions, they are not sitting there, like we academicians sometimes take these things very lightly. I must confess that we don't have the tools with us. The tools are not available to us. And we are really depending on their ways, their methodology to teach us. In the absence of that ability, the patient's ability to consent or refuse treatments, sometimes incompetent patient, patient in coma. What exactly do we do with it? In some cases, physicians, in consultation with the family and religious leader, determine the feasibility of taking action on the final, decision making. In other words, there are times when the physician is empowered. There are times when the family are empowered. There are times when the religious leaders, in most cases I find that religious leaders are the final broker of the opinion, because they are trusted. They are trusted by the families in many cases. In many cases they might, in some cases they might not, but in most cases I find that the religious leaders do have an important role to play, and they should be involved in such circumstances. Now, conditions for overriding. And I'm considering a real situation. I was taking care of the patient in Toronto for 4 years. And the patient was going through the MS and so many other complications. There was one thing about it. The patient was declining in every way, but he was conscious. He could make his own decisions. Whenever we asked him, can we shut off the ventilator? He said, no. Although he was not every day I saw his body was shrinking. I used to come almost monthly to talk to the family I never met the medical team, but it was more my concern was with the family. The family had taken care of him, that person, for 17 years. 17 years. Poor woman, the wife was really under the most difficult circumstances. Children were married. They had their own lives. It was all on the wife. How could you make those decisions? Can you override? Conditions when burden of treatment clearly offset benefits. There was no benefit whatsoever in this case. And in chronic organic, brain syndrome or kidney failure, whose compromised mental conditions and kidney functions would gradually worsen no matter what is done, leading to mounting and burdensome healthcare costs. Fortunately, the family was very rich. Wealthy family was able to pay for everything and anything. And yet, in view of the principle of preponderance, tarjih, murajjah, as we would say in jurisprudence, that this decision is better than this one is. And we will follow because it is murajjah. It is a preponderance over that decision. That kind of legal, terminology is available to us to give you an idea that 2 opinions are there. 3 opinions are there. Which one do we follow? That is murajjah. The principle of murajjah wants you to look at the proper benefits that could accrue to the person by following that. And in view of that principle of preponderance, it is judicious for surrogates, could be the medical team, could be the family, and clinicians to begin to continue therapy, knowing that it will produce a greater balance of benefit, pain, and suffering for patient incapable of choosing for or against such therapy. The patient is not asked. So there's no, consent available from the patient. Our principle of autonomy really doesn't work under certain circumstances. It's more communitarian. It's more collective decision-making. Sorry. Conditions for overriding. Second condition, futile treatment. Are they futile? Are they useless treatments? Sometimes medical team thinks otherwise. They would say, no, we don't prescribe anything without properly assessing what are the benefits. Even if the insurance is paying, we still would be very careful in giving you, a prescription for a treatment. Fine. So, full-time treatment is not obligatory when it offers no benefit to the patient. I'm talking about the Islamic point of view. If a patient is on LSE, he or she can no longer be harmed by cessation of treatment. So even if we stop the treatment, like in the case of Rasuli, by the way, when they wanted to stop that, and yet, the decision made by the Supreme Court, Canadian Supreme Court, was that no, we were going to, support that. Now, the wife is right. He can be kept alive, this and that. So it is important to consider, for example, if Islam regards such a condition as equivalent to death when LSE maintains heart and lung function. This is where the whole question of brain death also comes in. In that case, the treatment cannot be ruled as pointless. If the wife said, in Rasuli case, what really struck me was a very important issue. The wife said he was regaining consciousness. After 3 months, he started opening his eyes. He could feel the presence. Now, exactly how do we deal with it is a religious question. How do we handle that situation? The third condition, this is what I think this is the field that Dr. Padella is going to, I think, at least give us more insights in what he has done. Conditions to determine the quality of life. Quality of life judgments are most precarious in bioethics. Who determines the quality of life? My time is 5 minutes. It's important to note that when quality is sufficiently, life is sufficiently low, further intervention produces more harm than benefit for the patient. Talking about the Islamic view. Yes, thank you. For such a patient, we need only to determine which medically indicated treatment is obligatory and which is optional. Because there's no way, to impose one or the other. The choice is between further palliative treatment or no treatment, and no treatments. Mental retardation has been used sometimes, but I don't think that's right. Mental retardation is irrelevant in determining whether treatment is in patient's interests. I don't think we can really judge on that issue. So we have done the three. Now, we want to understand the principle of non-maleficence in Islamic bioethics. It's a very important issue. Nafy al-dharar. Whatever I decide about somebody beyond me, could be my spouse, my children, I should always be ethically sensitized on the question of, am I doing harm by my making those decisions? I'm talking about social ethics in general. But you can use it in all fields of ethical decision-making. Ethical decision-making is very much based on this concern about human interaction. My interaction, is it going to harm you? Is it going to cause you more pain and suffering? Sometimes, let's say, the whole question about confidentiality has been used, and Muslim jurists have been asked time and again, can we keep the information confidential because it's going to harm the patient psychologically? And many times, Muslim jurists have said, yes, it must be kept confidential. If it's going to cause harm, in that case, then we must not tell the patient or must not tell anyone in the family. Now, we know that here in this whole question, in our system, in North America, we do tell them. The first thing when I had my heart attack, when I was only 43 years old, I'm 75 by now, so I've lived longer. But the first time I had it, I still remember that was the first year in 1970, I think it was, 1977, when the new blood thinner had been introduced in taking care of the cardiac situations. And they would make me sign papers. Out of 10,000, one will die. Okay, all right, so I'm willing to die, So, in other words, the university, the hospitals are very careful about the legal implications of introducing new medications. Imagine in that situation, we are now making decisions about so many other things. Precocious measure, bil-ihtiyat. In bioethics, killing is conceptually and morally connected to absolutely unacceptable act. Nobody can even talk about that. You can't even think like that. Outside medical circles, as in administration of justice, for example, we see in Islamic law, for example, or in other systems of law, killings absolutely unacceptable is not assumed. Killing in self-defense or killing to rescue a person endangered by other person's immoral acts prevent us from judging an action as wrong merely because it is killing. Merely because it is killing. Conclusion about killing is as an evil act is contingent on the features of particular case. And we can't really always rule, by the law that no, this is wrong and wrong. We can't be so to speak, Kantian in that case. We need to be somehow cognizant of the facts that are affecting our decision making. Now, understanding suffering is also very, very important in the end-of-life decisions. Changing circumstances in a patient's health requires consideration of deteriorating condition that might rule out the duty of prolonging life when suffering becomes unbearable. It comes up in tube feeding. There are so many issues in the tube feeding. It's so emotionally charged issue. Even in the hospital situation, among the Catholics, among Muslims, everybody is discussing what should we do. Emotionally, you don't want to deprive a person from, hydration, from nutrition. You want to provide them. And yet, the major question still remains, how do we decide that? After all, what are we doing? Because it's not easy. Tube feeding, all the procedures that are involved are not easily administratable. They require careful evaluation. All right. So here you have the question about prolongation of treatment might cause even greater harm. We don't even know, because many times it's speculative. Speculation, and I think we have a right. That's how medicine is an art. You need to work with the patients for such a long time for you to understand how exactly science is going to interact and what is going to be absolutely possible. And the Sharia makes it obligatory to reject harm or harassment. You can't do that. You can't just make an easy decision, oh yeah, emotionally this is what it is. No, I think you're causing even more harm. How long are you going to do that? There is no obligation to prolong life when death is imminent. When the medical team is giving, and by the way, Muslim jurists are always in consultation with the medical team. They don't make a decision without knowing the case properly. And the way we tell them the case, medical personnel, when we tell them the case, that's how they make the decision. Nature must be allowed to take its course when all possible medical interventions to cure have been exhausted. Aggressive medical treatment is reprehensible, makruh, karaha. It's not even allowed. Don't even go on that. You're causing more harm. What are you doing about this? Sometimes these wealthy families that I have been, going to see their patients many a times, they want the person to be alive. And when the insurance company is keeping, paying the bills, sometimes you don't worry about the patient. You worry about your own personal, desire that, okay, I want to see my mother, there all the time, even if she's in the bed, even if she's bedridden, I still want to do that. Now, aggressive medical treatment is reprehensible when it ends up without any obvious benefit to the patient. Finally, this is my last, and I come back to Rasuli case, by the way. You have seen this already in the newspaper, but I'm taking sides with the dissenting vote. Yes, I'm not agreeing with the majority vote that was taken, by the court. I still am doubtful that was correct. Who should have the ultimate say in end-of-life decisions in the absence of legislation on that subject? This was the question in Ontario, Supreme Court. What exactly are we going to do about it when the case of Rasuli was, presented? No legal principle can avoid every ethical dilemma. That was the opinion given by, those who supported it. In other words, ethical dilemma is going to face, the medical professionals, whether they like it or not. Justice Andremet Carcassanders, I don't know how to pronounce that last name, Ontario's Healthcare Consent Act does not, and he's right, according to what I understand from studying all the jurists and juridical literature in Islam, I think that give patients or their substitute decision makers the right to insist on the continuation of treatment that is futile, useless, pointless, harmful, or contrary to medical standards of care. Medical standards of care is objective, it's not subjective. They all know what are we supposed to do under those circumstances. Law, the one who really, I admire that person who fought for that death with dignity. And I think it's worth keeping in mind that ultimately the question is, what is the dignity of a human person who's lying in the hospital bed with no hope whatsoever? What exactly are we doing? This is a very tough decision making. I must submit that I've participated in many cases in the University of Virginia hospital system, and many a times I have given a dissenting opinion that no, that's not the way to handle the patient's rights. But the hospital administration is always worried about the lawsuits that might follow. And therefore the decisions are made very much in terms of, I would say, pragmatic. And he was the one he known across Canada for his work during the 2003 SARS. I still remember that I was not able to travel to Toronto at that time, I remember. And in crisis in Toronto, appealed from death's doorstep for terminally ill patients in pain to be able to die with dignity. Thank you so much.
Dr. Sachedina, welcome to Toronto again.
I thought there was one
sorry.
person. Okay. No, that's fine. Thank you. Okay. All right. Yes, please.
Welcome to Toronto again, I would say. And your presentation highlights the actual scenario we are facing here in Ontario. I'm an Imam Abdulaziz Patel, leading with Muslim community, as well as I'm on the Law Commission's Advisory Committee on capacity to make decisions in palliative care and guardianship. So this is a legislation that will be, part of it is introduced in the Ontario legislature and more will be coming. We have been working for the past 3-4 years on this subject of when a substitute decision maker can come in and whether a power of attorney should be mandatory for every individual in the province. Because we are reaching a position where Human Rights Code in Ontario, and I'm a former commissioner of Ontario Human Rights Commission, that calls for religious accommodation. And this is why Rasuli's case is here before us as well for more than 3-4 years. So we are faced with the dilemma, and the Muslim community is still struggling to say, but you have outlined the harm and benefits, which is always overlooked by our scholars. And I have consulted a number of scholars, but from the other countries, and said, this question you have in Canada because you have free health care. In other countries, we have to pay for life support machines, and therefore we cannot afford that. Many cannot afford that. So the question doesn't arise whether it's a natural death or a death for disconnecting. But here in Toronto, I have witnessed 2 cases where life support machine has been disconnected, and one person has lived 15 years, performing number of Hajj and Umrah as well after disconnecting here in St. Michael Hospital. And another person as well that have lived for a few years. So Muslim community still cannot make out. The question that I would say is, this is a decision for people here in North America and not in Muslim countries that can make decisions for the community. And any suggestion, because substitute decision maker in the family still doesn't sort of prove that they can force the hospital to disconnect the life support machine.
Thank you for those comments. I think that I do understand the sensitivity of the topic for the Muslim community, or for any community, religious community, that is trying to somehow, bring in what I call the religious foundations of bioethics in conversation with the hospital care. How exactly do we negotiate the space? And I think it's time to bring back la darar wa la dirar fil Islam in a very prominent position in all social matters. All social matters are interactive. There's interaction going on between human beings. And one of the most important studies written on this principle is by Ayatollah Sistani himself. He has written on this whole issue, not only from the Islamic, from the Shia perspective. It's a Muslim rule. It's the Prophet who taught that, look, you're not going to cause harm, and you're not going to reciprocate harm with harm. You're going to solve your problems more interactively in justice and fairness. Fine, okay. So that's what the Islam is teaching. And I think that principle has somehow been, overshadowed by maslaha, public interest. What do you mean by public interest? More important is what the individual is going through, what the family is going through. You are not going to submit to utilitarianism of some kind by insisting upon something that does not produce what we call the dignity that you and I are looking for in human rights of individuals. Yes, there was another question.
Yeah. So thank you so much for the presentation. I appreciate it. It was very informative. And my question is, so when you were exploring the case, you talked a little bit about what would harm the family, perhaps, or benefit the family. And I thought that this was especially interesting because I know at UHN and in Western liberal context generally, we focus on patient-centered care and on what would harm or benefit the patient. So sometimes I wonder whether a perspective of family-centered care would actually be more appropriate when providing culturally sensitive care. So I just want to hear your thoughts about patient-centered care versus family-centered care in a culturally sensitive care kind of setting.
There is usually a lot of conflict, by the way. What Islamic law, what the Sharia does is that it's aware of human proclivity to make a decision in their own interest. So even if the children are not spared, if the children make a decision of getting rid of, let's say, the old man who is lying in the hospital by, saying that, get rid of him. Then they will lose inheritance rights. So the Sharia is aware of the human weaknesses. When it comes to this, it says, okay, let's try to read the intentions of the people. It's not always easy. It's too subjective. But through what they say, what they do, you might surmise circumstantially that the people are trying just simply to, get rid of the person. Oh yeah, you can stop all the machines. You can do this, you can do that. And although the physicians are then, look, there is a chance he or she might regain consciousness. And yet, the family might say, no, I think that we had enough. Now, to say that is a conflict in what we call the sense of familial connections. How can I do such a thing, let's say, when I don't like my spouse, and I make a decision about her, when she doesn't even know that I am the one who is actually prompted the medical team to do it. So I'm committing, actually it's a sinful act, but it's also consequential, because it really is showing my weaknesses when I'm confronted with ethical tensions. Here is my interest versus my wife's interest. Who's going to do that? Now, I have not signed that advance directives because my wife is totally against it. She says, if you go to the hospital, I will make the decision about you. You don't have to make a decision about it. And the same thing applies to me. In other words, we have not, surrendered, so to speak, our advance directives because there might be a conflict of interest. And how do we protect that is still a matter that has not been resolved. It requires psychological understanding of what exactly are we involved in making that decision. Thank you very much. Thank you.